Hello, my name is Jawahar Al-Khatib. I'm an orthopedic surgeon who has worked with Dr. Ivan Wong in Dalhousie University, Halifax, Nova Scotia. Today, we are describing a novel surgical technique for an all-arthroscopic augmentation of isolated subscapularis repair. Here are our disclosures. The patient is positioned into a 30-degree of semilateral decubitus. Arm is placed in a pneumatic arm holder with a balanced traction in 60-degree of abduction and neutral rotation. Surface landmarks are drawn, outlining clavicle, acromion, scapular spine, AC joint, and coracoid process. For this procedure, our portals include posterior, intra-inferior, percutaneous intrasuperior, and a low lateral portal. Standard diagnostic arthroscopy is completed from the posterior portal, outlining biceps tendon, labrum, glenohumeral articular surface, capsular reflection, and rotator cuff insertion. An inside-out anterior-inferior portal is then created. This portal will be the primary working portal throughout the procedure. The previous subscapularis repair is visualized from the posterior portal, showing failure of healing at the suture anchor insertion point. Fibers are thin, laminated, and pulled off the intact knots. The rotator interval is released with a shaver and ablator to allow full visualization of the intrasuperior aspect of the subscapularis. Previous suture material is then removed with a shaver and a grasper. The subcoracoid space is also released. It is important to separate the conjoint tendon from the subscapularis using an ablator probe. Position the arm slightly forward flexed to see over the top of subscapularis and adducted to keep the conjoint tendon medial, and do all the working lateral away from the brachial plexus. We then recommend to switch to the 70-degree lens for the remaining of the procedure. The 70-degree lens will help to have an over-the-top view for the subscapularis. Now, the subcoracoid space is further released. We then proceed to perform a standard subscapularis repair. The lesser tuberosity footprint is prepared with an ablator and a shaver until subcortical bone bleeding is visualized in order to promote healing. Any previous loose suture remaining is also removed. Grasp the tissue to ensure that it reaches to the footprint. Tissue quality here is poor and delaminated. We then performed a single row technique using a double-loaded all-suture anchor. Using a spectrum shuttling device, sutures were passed into the subscapularis in a modified Mason-Allen configuration. It is important to pass through all layers of the tear in one bite to help prevent cutting through the tissue. After completion of the standard repair, create the low lateral portal using an outside-in technique. The spine and needle should align parallel to the upper border of subscapularis. This portal will be used to pass the graft. Before the graft insertion, an accessory intrasuperior portal is also created. A switching stick is introduced to retract the deltoid away to improve visualization and ensure wider working space. An assistant must keep the deltoid retracted throughout the graft insertion and fixation. 3 points to keep in mind while inserting the graft. 1. Graft must be aligned parallel to the subscapularis. 2. Graft must sit lateral to conjoint tendon to avoid getting into neurovascular bundle and medial to biceps groove, and doesn't go beyond subscapularis footprint. To achieve that, keep the arm adducted, externally rotated, and slightly forward flexed. 3. The most inferior portion of the graft must be visualized to ensure it doesn't hit the three sisters vessels. This is achieved by using the 70-degree scope. While keeping the graft held and aligned, the fixation stable device is introduced from the intra-inferior portal. Stables are deployed to fix the graft going from medial to lateral of the footprint. After fixation is completed, now we see a final view of the augmented repair visualized from the posterior portal, indicating maximal augment coverage.